Welcome back, everyone. A massive welcome to our dedicated audience of physiotherapists and vestibular rehabilitation specialists. I am absolutely thrilled to have you here for this masterclass explainer. Today, we're focusing squarely on executing and interpreting diagnostic maneuvers for BPPV. Look, if you're working in a busy clinic, this is literally your bread and butter. We're going to build a protocol-driven framework that will completely transform how you approach that critical first session with a dizzy patient. So let's just get right into it. Right off the bat, to firmly establish the evidence-based foundation of today's clinical guide, I need to note that this explainer is based on BPPV, recognizing and treating all canal variants, posterior, horizontal, anterior, and atypical presentations, published by Australian Dizziness Clinics. Every single metric, technique, and clinical pearl we discuss today comes directly from this comprehensive review. Okay, I want you to literally burn this phrase into your clinical mindset. History suggests, but the eyes confirm. When a patient walks into your clinic telling a story of brief, intense vertigo triggered by, say, rolling over in bed or looking up at a top shelf, well, that history strongly points to a positional cause. But here's the catch. History alone never actually confirms which semicircular canal is involved. Until you carefully watch the patient's eyes during a diagnostic maneuver, the canal is a complete mystery. And this is absolutely crucial because if you apply the wrong treatment maneuver, you can actually move that calcium carbonate debris from one canal right into another, creating a completely new variant right there in your clinic. Bottom line, the diagnostic maneuver is the entire diagnosis. So here is our roadmap for today. First, the diagnostic imperative. Second, the Dix-Hallpike for the posterior canal. Third, the supine roll for the horizontal canal. Fourth, variant subtypes. And finally, your key clinical takeaways. Section 1, the diagnostic imperative. Let's dive into why a systematic diagnostic approach is basically non-negotiable. And this brilliantly illustrates the decision tree we use. It's the absolute backbone of your assessment. Right at the top, you can see how we branch into two primary tests. Over on the left, we've got the Dix-Hallpike for the posterior canal. On the right, the supine roll for the horizontal canal. We're also laying out the expected outcomes here, a beat torsional nystagmus for the posterior and either geotropic or apogeotropic for the horizontal. Now, definitely take note of that red warning box. If you ever see direction changing or vertical nystagmus lasting past 60 seconds, that's a central mimic. You need to hit pause right there and refer that patient out to a vestibular physician. So let's see how this builds into our very first major test. Section 2. Posterior canal and the Dix-Hallpike. This is your undisputed gold standard. So the mechanics of the Dix-Hallpike require absolute precision. Honestly, accuracy here is the difference between a definitive diagnosis and completely missing the mark. Step 1, your patient starts sitting, and you turn their head exactly 45 degrees toward the side you're testing. Step 2, rapidly lower them to a supine position. Now step 3, and actually this is where a lot of us fall short, the neck must be extended roughly 20 degrees below the horizontal plane. That 20-degree drop is the secret sauce. It aligns the posterior canal perfectly with gravity, forcing any debris to slide down to the lowest point. And of course, you repeat this on the opposite side to compare. So, what happens when you finally get them into that position? Well, you watch those eyes like a hawk. In true posterior canal BPPV, you're looking for 4 very specific things. First up, latency. There's going to be a delay of about 2 to 10 seconds before the nystagmus even starts. This is a cardinal feature, right? The particles just need a second to overcome inertia and endolymphatic drag. Second, the direction. It will be upbeating and torsional, rolling toward the lower dependent ear. By the way, whichever ear is facing down when the test is positive, yep, that's your affected canal. Third, the duration. It typically lasts 10 to 30 seconds, swelling in intensity and then fading out, a classic crescendo-decrescendo pattern. And finally, when you sit them back up, the nystagmus will often briefly reverse direction. Just a quick aside, if they get immediate vertigo without any nystagmus, you're often looking at anxiety rather than true BPPV. Section 3, horizontal canal and the supine roll. So what's your next move if the Dix-Hallpike doesn't match our expectations? If the posterior canal isn't the culprit, we look at the horizontal variant, which makes up about 10% of cases. And the test for this is the supine roll. It's wonderfully straightforward, but it's all about speed. Step 1. Patient lies totally supine, head neutral on the bed. Step 2. You rapidly roll their head to one side. Think ear-to-ear motion. Step 3. Observe the nystagmus while they stare straight ahead. Once things settle down, bring the head back to neutral, wait for the dizziness to pass, and rapid roll to the other side. Now, unlike the posterior canal, Horizontal canal testing usually triggers nystagmus on both sides, which kind of makes interpreting it like a giant puzzle.
Section 4. Variant subtypes. Let's solve that puzzle and decode those horizontal nystagmus patterns.
Now, what's really interesting about this side-by-side comparison is that it shows the critical fork in the road. When you roll the patient, the nystagmus beats purely horizontally, but the direction tells you the physical state of the crystals. On the left, we have geotropic. Geo meaning earth, so it beats toward the ground or the lower ear. It'll show up on both sides, but the affected ear gives the stronger response. Now on the right, we have apogeotropic. Apo meaning away from, so it beats toward the upper ear, away from the floor. And here's the tricky part. In the apogeotropic variant, the affected ear actually gives the weaker response. Let's dig into the why behind the what for a second. Why do these eyes behave so differently? It all comes down to canalithiasis versus capulithiasis. A geotropic response means canalithiasis. The otoconia, those microscopic 3 to 30 micrometer particles, are just free-floating in the fluid. Gravity pulls them, fluid moves, you get transient nystagmus. But an apogeotropic pattern? That points to capulithiasis. The particles have literally adhered directly to the cupula. It's like a persistent weight pressing down, creating a sustained, away-from-the-ground nystagmus. Geotropic is common and pretty easy to treat. Apogeotropic is rarer and usually takes a lot more persistent therapy to clear up. Section 5. Key clinical takeaways. Let's quickly consolidate these hard facts. I want to reiterate these metrics one final time, just to completely cement them for your next clinic day. Dix-Hallpike, you need that 2 to 10 second latency, upbeat, torsional nystagmus toward the dependent ear, lasting 10 to 30 seconds. For the supine roll, geotropic equals canalithiasis, the free-floating debris. Apogeotropic equals capulithiasis, the stuck debris. Okay, so you've done all the hard work. You've isolated the exact variant. But here is my final question for you. What happens if you now apply the wrong repositioning technique? If you use an Epley on a horizontal issue or a BBQ roll on a posterior variant? There's no way around it. You aren't just failing to help them. You risk dumping that debris right into a completely different canal, creating an absolute multi-canal nightmare. And honestly, that is exactly why mastering the diagnosis first is 100% non-negotiable. But don't worry, we're covering the fixes next time. In part 3 of this series, we're going to walk step by step through the canal-matched repositioning library. Epley, Semont, BBQ roll, the whole shebang. You absolutely won't want to miss it. For more resources, go ahead and visit AustralianDizzinessClinics.com, and please remember to subscribe and rate the explainer. Until next time, keep your eyes on the nystagmus because the wrong maneuver might just be the one that makes your patient's world spin in a whole new direction.